In this video, we'll be discussing the anatomy of the extensor forearm and the hand. Let's begin with the extensor forearm. The muscles of the extensor compartment extend the wrist, the fingers, and the thumb. The extensor muscles are divided into a superficial and deep layer. The superficial group is comprised of 6 muscles, all of which are innervated by branches of the radial nerve. The brachioradialis muscle, shown here, is categorized as an extensor muscle because of its innervation by the radial nerve. Functionally, however, the brachioradialis muscle acts to flex the forearm in the mid-prone position. It has this action because the muscle crosses the anterolateral side of the elbow joint, whereas all the other extensors cross the posterior aspect of the elbow joint. The motion of raising an axe above one's head to chop a piece of wood is mostly accomplished by the brachioradialis muscle. This action demonstrates flexion in the mid-prone position. Notice the attachments of the brachioradialis muscle. It originates from the supracondylar ridge, here on the lateral side of the humerus, and it inserts onto the styloid process of the radius. Notice that it does not cross the wrist joint. Therefore, it does not act on the wrist. It only flexes the forearm, again in the mid-prone position. The remaining 5 muscles of the superficial extensors are true extensors, and they originate from a common extensor tendon which attaches to the lateral epicondyle of the humerus. Here's the lateral epicondyle of the humerus where that tendon attaches. Notice that we're looking at a posterior view of the forearm. The extensor carpi radialis longus muscle, shown here, arises mostly from the lateral supracondylar ridge and has some fibers originating from the common extensor tendon. As its name suggests, the extensor carpi radialis longus extends the wrist on the radial side and is the longer of the 2 extensor carpi radialis muscles. The extensor carpi radialis longus will also help to participate in radial deviation of the wrist. Its sibling, the extensor carpi radialis brevis muscle, shown here, has the same function as the extensor carpi radialis longus muscle. However, it is the shorter of the 2 muscles. The word brevis means short. Distally, the extensor carpi radialis muscles attach to the base of both the 2nd and 3rd metacarpal bones. As such, they will extend the wrist and participate in radial deviation of the wrist. The largest muscle belly in the superficial extensor compartment is that of the extensor digitorum muscle, shown here. This muscle sends out 4 tendons, which attach to the digits through something called the dorsal extensor expansions. These are sometimes referred to as the expansion hoods. In addition to assisting in wrist extension, the extensor digitorum muscle is mainly responsible for extending the MCP joints, shown here. The extensor digitorum muscle also indirectly assists in extending the pip and dip joints. The extensor digiti minimi muscle, shown here, gives the pinky finger a little more mobility in extension compared to the ring finger, for example. The muscle belly of the extensor digiti minimi muscle is relatively slender and is positioned between the extensor digitorum muscle and the extensor carpi ulnaris. The extensor carpi ulnaris participates in both wrist extension and ulnar deviation of the hand. Just like the flexor carpi ulnaris muscle, the extensor carpi ulnaris also attaches to the base of the 5th metacarpal, shown here. And as a reminder, all of these muscles are innervated by branches of the radial nerve. In a previous video, we briefly discussed golfer's elbow, which is inflammation of the common flexor tendon at the medial epicondyle. It is also called medial epicondylitis. Inflammation of the extensor tendon is referred to as lateral epicondylitis, or it is colloquially known as tennis elbow. Repetitive overuse of the extensor forearm muscles can cause inflammation. For example, the backhand motion required to effectively swing a racket relies specifically on the extensor carpi radialis brevis muscle. Micro tears in the common extensor tendon can lead to inflammation and subsequently can lead to pain. Again, this condition is referred to as lateral epicondylitis or tennis elbow. Also recognize there are particular occupations which are more prone to lateral epicondylitis than others. Painters and carpenters, for example, regularly extend their wrist to paint and hammer. As such, individuals in these occupations are at greater risk for developing lateral epicondylitis. There are 5 muscles of the deep layer of the extensor forearm. The supinator muscle, shown here, works in conjunction with the biceps brachii muscle to supinate the forearm. The 2 heads of the supinator muscle pull on the proximal radius to accomplish this task. The thumb alone has 3 muscles that act upon it in the posterior compartment. The abductor pollicis longus muscle is responsible for abducting the thumb, which means that it moves the thumb away from the other fingers. And both the extensor pollicis longus muscle, shown here, in conjunction with the extensor pollicis brevis muscle, act to extend the thumb. Because of the location and orientation of the extensor pollicis longus muscle belly, its tendon relies on a small bump on the distal radius called Lister's tubercle, shown here. Lister's tubercle acts like a pulley to align the tendon of the extensor pollicis longus with the thumb for appropriate thumb extension. Notice that the extensor pollicis longus muscle and its tendon inserts onto the distal phalanx of the thumb, while the tendon of the extensor pollicis brevis inserts onto the middle phalanx. And lastly, the extensor indicis muscle, shown here, assists the extensor digitorum muscle in giving greater mobility to the index finger. In a condition known as de Quervain's disease, the tendons of the abductor pollicis longus muscle and the extensor pollicis brevis muscle become inflamed as they cross the styloid process of the radius on their course to the thumb. Patients with this condition often present with pain along the radial side of their wrist, especially when they extend the thumb or radially deviate their hand. Patients will often point to the styloid process of the radius when localizing the area of pain they experience. To examine a patient for de Quervain's tenosynovitis, the Finkelstein test can be performed. To conduct this test, the patient's fingers are folded over the thumb, and the patient's hand is deviated toward the ulna in order to elicit stretching of the abductor pollicis longus tendon and the extensor pollicis brevis tendon. If the examiner elicits sharp pain from the patient, then de Quervain's tenosynovitis is likely. Now let's discuss the innervation of the extensor muscles. Realize that in the depths of the cubital fossa, the radial nerve gives rise to a superficial branch and a deep branch. Before giving rise to these branches, the radial nerve itself innervates the brachioradialis muscle, as shown here, as well as the extensor carpi radialis longus muscle, shown here. After the radial nerve sends off the branches to those 2 muscles, it then divides into the deep and superficial branch. The deep branch of the radial nerve innervates both the extensor carpi radialis brevis muscle and the supinator muscle shown here by the X. In the image to the right, notice how the deep radial nerve courses between the 2 heads of the supinator muscle. Here's one head shown by the X, and the second head demonstrated by the triangle. As the deep radial nerve emerges between the 2 heads of the supinator muscle, it changes names to become the posterior interosseous nerve. I'll often abbreviate this nerve PIN. Notice how the posterior interosseous nerve accompanies the posterior interosseous artery, which, as you recall, originated from the common interosseous artery in the anterior compartment of the forearm. The posterior interosseous nerve will innervate the rest of the muscles of the extensor compartment of the forearm. Recognize that the superficial radial nerve is purely a cutaneous nerve, and it runs under the cover of the brachioradialis muscle, as shown here. Near the wrist, the superficial branch of the radial nerve spirals around to innervate the dorsum of the hand, and it provides exclusive cutaneous innervation to the first dorsal web space, which is the area indicated here by the purple. The area shaded in purple represents the cutaneous distribution of the superficial branch of the radial nerve. Notice how this nerve does not go all the way to the fingertips. Notice that it does split the innervation for the ring finger, so half of the innervation of the ring finger is from the superficial branch of the radial nerve, whereas the ulnar side of the dorsum of the hand is supplied specifically by the dorsal branch of the ulnar nerve, whereas the fingertips of the thumb, the index finger, and the middle finger are still supplied by the median nerve. By way of dermatomes, the dorsum of the hand is mostly supplied by the C7 dermatome, which courses mostly through the superficial branch of the radial nerve. Notice that the ulnar side is also supplied by the C8 dermatome, which in this case would be transmitted through the dorsal branch of the ulnar nerve. To test the function of the superficial branch of the radial nerve, you would do so by testing in the area here of the first dorsal web space. This can be done by pricking the patient's hand with a pin or a needle, for example. To test the ulnar nerve, you would want to prick the patient's hand either on the palmar side in this area here, indicated by the X, or on the dorsal side in the area indicated by the X here. Another common location for testing the ulnar nerve is at the very tip of the pinky finger. So what happens if the radial nerve is damaged above the elbow? Well, the result is a condition called wrist drop, in which the patient loses function of all of the extensor muscles innervated by the radial nerve. The extent of functional loss, of course, is dependent upon the exact location of the nerve lesion. The patient's right hand in this image is completely limp. If you ask this patient to supinate his forearm, weak supination would be possible because of the biceps brachii muscles. The biceps brachii would be unaffected in his right arm because it's innervated by the musculocutaneous nerve and not by the radial nerve. If the radial nerve is in fact lesioned above the elbow, you would also expect the patient to experience sensory loss or numbness in the area of the first dorsal web space, indicated by the X. He would also likely have sensory loss along most of the posterior aspect of the forearm and the majority of the hand, especially in the areas supplied by the superficial branch of the radial nerve. The anatomical snuff box is a triangular-shaped divot formed on the lateral wrist when the thumb is in full extension. There are 3 tendons of the thumb that form the boundaries of the anatomical snuff box. To remember this, I like to use the analogy of the brevis sandwich. That is, the brevis tendon is sandwiched between the 2 longest tendons. The upper border of the anatomical snuff box is formed by the tendon of the extensor pollicis longus muscle, shown here. And the lower border of the anatomical snuff box is formed by 2 tendons. It is formed by the tendon of the extensor pollicis brevis and the tendon of the abductor pollicis longus muscle. Again, the brevis tendon is sandwiched between the 2 longest tendons. The floor of the anatomical snuff box is formed by 2 carpal bones. The scaphoid bone, shown here, is more proximally located compared to the trapezium, shown here. Also coursing through the depths of the snuff box is the radial artery, as shown here. And coursing over the roof of the anatomical snuff box is the superficial branch of the radial nerve. If an individual fractures his or her scaphoid bone from a fall on an outstretched hand, it can present as pain and tenderness in the anatomical snuff box. The area indicated here by the asterisk is where a physician would palpate to elicit pain if the scaphoid bone is broken. In the X-ray shown to the right, here's the outline of the scaphoid bone, and notice the arrow is pointing to the scaphoid fracture. Of all 8 carpal bones, the scaphoid bone is the most frequently fractured. This is because when transferring weight from the hand to the forearm, that weight is transmitted through the scaphoid bone onto the radius. Extension and radial deviation of the wrist are also likely to elicit pain in patients with a fractured scaphoid bone. If you've been paying really close attention, you might realize that this pre-labeled image to the left is incorrect. Recall that the brevis tendon is sandwiched between the 2 longest tendons. To correct this image, simply invert these 2 labels. Now let's discuss the anatomy of the hand. To begin, I would like to quickly review the movements of both the digits and the thumb. By waving bye-bye, you are demonstrating both flexion and extension of the fingers, specifically flexion and extension at the MCP joint, shown here. Abduction of the digits means that the digits move away from the midline of the middle finger. And adduction or adduction of the digits means that they move back toward the midline of the middle finger. Abduction of the thumb means that it is taken away from the other digits, whereas adduction of the thumb means that it is brought back toward the fingers. When you point your thumb for hitchhiking, you're demonstrating extension of the thumb. This image demonstrates thumb flexion, and lastly, opposition refers to the fact that the thumb can touch all of the fingers. Here's a quick demonstration. This represents abduction of the digits, and here is adduction or adduction of the digits. This is flexion of the digits, and here's extension of the digits. Here is abduction of the thumb and adduction of the thumb versus flexion and extension of the thumb. Again, flexion, extension, adduction, abduction. And lastly, opposition. And here's an example of ulnar deviation, also called medial deviation of the hand at the wrist joint, versus radial deviation, also known as lateral deviation of the hand at the wrist joint. As was previously presented, the palmaris longus tendon blends with the palmar aponeurosis, as shown here. The palmar aponeurosis is a thickening of the palmar fascia that helps to protect the hand from penetrating injuries. In the fingers, the same tissue that forms the palmar fascia forms fibrous digital sheaths, as shown here. These strong sheaths form tunnels through which the tendons of the flexor muscles and their respective synovial sheaths pass. Just like the flexor retinaculum prevented bowstringing of the tendons at the wrist joint, the fibrous digital sheaths prevent bowstringing of the dip, pip, and MCP joints. The synovial sheaths, shown here, just deep to the fibrous digital sheaths, are responsible for ensuring that the various tendons slide freely over one another during movements of the fingers. In the middle image, notice that the tendons of the index, middle, and ring fingers have separate synovial sheaths. In a condition called tenosynovitis, which is an infection of the tendon and the synovial sheath, infections of the middle 3 digits are usually confined to the infected finger. If the infection is left untreated, the synovial sheaths could rupture, causing spread of the infection to the mid-palmar surface or space. Because the synovial sheath of the pinky finger shown here is continuous with the common flexor sheath, which is also known as the ulnar bursa, tenosynovitis in the little finger can spread from the little finger to the common flexor sheath and even through the carpal tunnel and into the anterior forearm. And similarly, tenosynovitis in the thumb can spread through the radial bursa, shown here, again through the carpal tunnel, and into the anterior forearm. There are 4 common signs of tenosynovitis infections. First, it presents with tenderness along the course of the flexor sheath, especially if the thumb, pinky, or palm have been affected. There's also likely to be systematic enlargement of the affected digit. In addition, the digit will appear slightly flexed at rest. This is due to the inflammation tightening the tendons. And lastly, patients will often experience pain along the tendon with passive extension. In a condition known as Dupuytren's contracture, the longitudinal bands of the palmar fascia, shown here, become fibrotic and thickened, and as a result, they shorten. The shortening of these bands pulls the affected finger into a partially flexed position. The 2 most commonly affected fingers are the pinky and ring finger. The only way to correct this pathologic shortening of tissue is to surgically sever the longitudinal bands of the palmar fascia. The intrinsic muscles of the hand are what allow us to perform very fine motor movements. The mass of muscles forming the thenar eminence are the muscles of the thenar group. The thenar group is the bulge of muscle on your palm at the base of your thumb. And likewise, the mass of muscle that forms the hypothenar eminence are the muscles of the hypothenar group. The hypothenar eminence is the mass of muscle located at the base of the pinky on your palm. In this image, this grouping of muscles represents the thenar eminence, and this grouping of muscles represents the hypothenar eminence. You'll notice on this slide that the muscles of the hypothenar group are grayed out. You are not responsible for these muscles. We'll just refer to them collectively as the hypothenar eminence or group. You do, however, need to know that this group is innervated by the deep ulnar nerve. The thenar group is comprised of the abductor pollicis brevis muscle, shown here, which is the superficialmost muscle of this group. As its name suggests, it assists in abducting the thumb. The flexor pollicis brevis muscle is shown here, and it will be responsible for assisting in thumb flexion. Just like the flexor pollicis brevis, the opponens pollicis, shown here, is also immediately deep to the abductor pollicis brevis. It's a little hard to see, but you can see a sliver of it right here. The opponens pollicis muscle permits the action of opposition. Do recognize that all 3 muscles of the thenar group are innervated by the recurrent branch of the median nerve. We'll see an image of this in just a moment. And the last muscle labeled on this image is the adductor pollicis muscle, indicated here by the X. This muscle has 2 heads, a transverse head, which you're seeing here, and an oblique head, which is hidden by the thenar eminence. As its name suggests, the adductor pollicis muscle adducts the thumb, bringing it closer to the fingers. This muscle, the adductor pollicis, is innervated by the deep ulnar nerve. The word lumbrical means worm-like. These very slender, elongated muscles are interesting because they attach from the tendons of the flexor digitorum profundus to the dorsal extensor hoods. Let's take the first lumbrical as an example. Notice how this lumbrical attaches from the FDP tendon associated with the index finger. The muscle fibers of this lumbrical spiral around to insert onto the extensor side of the index finger. As such, because of this spiral orientation, the lumbricals function to flex the MCP joints, and they extend the PIP and dip joints. I like to refer to these muscles as the bye-bye muscles. I'll demonstrate their function in the next slide. Of the 4 lumbricals, the first 2 lumbricals, number 1 and 2, are innervated by the median nerve, whereas lumbricals 3 and 4 are innervated by the deep ulnar nerve. Here's the function of the lumbricals. Again, the lumbricals will flex at the MCP joints, and they will extend at the dip and PIP joints. Here is flexion at the MCP joint, but notice the extension at the PIP and dip joint. Again, these are the bye-bye muscles. Again, the 3rd and 4th lumbricals are innervated by the ulnar nerve. If the ulnar nerve is compromised, denervation of the 3rd and 4th lumbricals can present as a claw hand deformity. Here's what this deformity looks like. When the hand is at rest, the ring and pinky fingers remain hyperextended at the MCP joints. With the ulnar nerve compromised, this means the lumbricals can no longer perform their main functions. In other words, they can't flex at the MCP joints. Therefore, the extensor digitorum muscle, abbreviated ED, will pull the ring and pinky fingers into extension. Recognize that normal hand function relies on an intricate balance between hand flexors and extensors. Whenever this balance is disrupted, we have a deformity. Another way to describe this abnormal extension of the pinky and ring finger is to say that the extensor digitorum muscle is unopposed. You'll also notice in this deformity, the PIP and dip joints, shown here, are pulled into slight flexion. With the lumbricals out, they are no longer able to extend the dip and PIP joints. As such, the FDS and the FDP muscles are unopposed. Do recall that the ulnar half of the FDP, the flexor digitorum profundus muscle, is also innervated by the ulnar nerve. That being said, if the injury to the ulnar nerve is at the elbow, for example, then the ulnar half of the FDP muscle would also be affected in addition to the lumbricals and other intrinsic muscles of the hand. However, the tonic contraction of the flexor digitorum superficialis muscle, which recall is innervated by the median nerve, would still pull the pinky and ring fingers into slight flexion. That is, flexion at the PIP joint specifically. I also want to remind you that in the fingers, the extensor digitorum muscle acts principally on the proximal phalanges. In other words, it acts to extend the MCP joints. Extension of the dip and PIP joints is predominantly accomplished by the lumbrical muscles. Working through an explanation of why claw hand presents as it does will help you on the exam, because you'll be responsible for localizing nerve lesions, and if you can explain your way through this particular condition, it will certainly help. So put a big star next to this and be sure to revisit it. Here's a look at the dorsal extensor hoods, shown here. Notice how the extensor digitorum tendon, shown here, ends in the expansion hood. And also notice how the tendons of the lumbricals come up to attach to the sides of the expansion hoods. And notice that they do this after they cross the MCP joint. In this second image, you'll notice that contraction of the lumbricals in this direction puts tension on the extensor expansion hoods. thereby extending both the pip and the dip joints. And lastly, figure C shows how the lumbricals can be isolated for testing. Notice first of all how the wrist is in full extension in order to immobilize the extensor digitorum muscle. With the wrist in full extension, the patient is then asked to extend both the pip and dip joints. The last important pair of intrinsic hand muscles for fine motor movements are the interossei muscles. These muscles include the palmar interossei and the dorsal interossei. We often refer to these muscles as the pads and dabs in order to help you to remember the function that's paired with each muscle. The pads, for example, of which there are 3, represent the palmar interossei. The palmar interossei are responsible for adducting the fingers, which means that they bring the fingers closer to the midline of the middle finger. That being said, the P in pad represents palmar interosseus, whereas the AD in pad represents adduction, its function. In order to test the palmar interossei, you can have a patient hold a piece of paper between their fingers, and you can, as the examiner, try to remove that piece of paper. As long as the patient can maintain strong adduction so that the paper can't be removed, then the palmar interossei are intact and functioning. The dabs refer to the dorsal interossei, and they are responsible for abducting the fingers. Recall that finger abduction means that the fingers are moving away from the midline of the middle finger. To test the function of the dorsal interossei, the examiner will often hold the fingers together under light pressure and will ask the patient to abduct the fingers against resistance. Normal abduction is a sign of normal muscle and nerve function. I also want to point out that the first dorsal interosseous muscle shown here forms the mass of the first dorsal web space of the hand. This is worth mentioning because compromise to the deep ulnar nerve, which innervates all the ossei muscles, can present as wasting in the first dorsal web space. In other words, if there is atrophy of the first dorsal interosseous muscle, this could be an indication that the deep ulnar nerve is compromised. Here's a nice overview of the motor innervation to the intrinsic muscles of the hand. Recall that the median nerve innervated all of the muscles of the anterior forearm except for the flexor carpi ulnaris muscle and the ulnar half of the FDP. In the hand, it is also responsible for innervating the thenar eminence, shown here, as well as the first 2 lumbricals, indicated here. All of the other intrinsic muscles of the hand are innervated by the deep ulnar nerve. The ulnar nerve in this image is shown in black. So let's recap. The ulnar nerve is responsible for innervating the muscles of the hypothenar eminence. It is responsible for innervating the 3rd and 4th lumbricals. It also innervates both the palmar and dorsal interossei muscles, and it innervates the adductor pollicis muscle. Let's go back to the median nerve for just a moment. Specifically, the part of the median nerve that innervates the thenar eminence is referred to as the recurrent branch of the median nerve, as shown here by the green arrow. In the lower left image, this demonstrates the cutaneous innervation of the hand by both the median and ulnar nerves on the palmar surface and the ulnar and radial nerves on the dorsal surface. The X's indicate areas of exclusive innervation. So for example, if you want to clinically test the ulnar nerve, it's best to test it here at the pinky. Similarly, if you want to test the median nerve, the cutaneous innervation that is, test it here at the index finger. And if you want to test the cutaneous innervation of the superficial branch of the radial nerve, testing here at the first dorsal web space is the best location. Notice in this image that the area over the flexor retinaculum is innervated by the median nerve. So too is the area of the proximal palm. This is accomplished by a branch called the palmar branch of the median nerve, which I'll draw in here, extends from the median nerve, courses over top of the flexor retinaculum, and innervates the proximal area of the palm, shown here. Again, this very small nerve is referred to as the palmar branch of the median nerve. Notice how the median nerve itself courses deep to the flexor retinaculum as it courses through the carpal tunnel. Now let's look at the arterial supply of the hand. The superficial palmar arch, shown here, is positioned superficial to the flexor tendons, and the deep arch is located deep to the flexor tendons. Here's the deep arch. Recognize that the ulnar artery, shown here, is the main contributor to the superficial palmar arch, and the radial artery, shown here, is the main contributor to the deep palmar arch. However, there is clearly an anastomosis between the ulnar and radial arteries through both the superficial and the deep arches. Common palmar digital arteries arise from the arch, as shown here, and they course between the metacarpal bones. From the common palmar digital arteries arise proper digital arteries. These proper palmar digital arteries, along with the proper palmar digital nerves, supply the digits. An arterial puncture is a medical procedure performed to obtain a sample of arterial blood for gas analysis. The most common site for arterial puncture is the radial artery at the wrist. Because of the potential for formation of an obstructing thrombus at the site of the arterial puncture, it is recommended that the operator first demonstrate the presence of good collateral circulation in the hand. And since there's a possibility that the radial artery could become obstructed by a thrombus, the collateral flow would be coming through the ulnar artery. To demonstrate the presence of good collateral circulation, an Allen test can be performed. The Allen test is performed by having the patient clench their fist several times while the operator occludes both the radial and the ulnar arteries at the wrist, as shown by the X's. The patient then extends their fingers, palm up, which should show a blanched hand. As the operator releases the pressure on the ulnar artery, shown here, the hand is observed for blushing, which is the recoloring of the hand back to its normal coloration. If the normal coloring of the hand does not return within 5 to 10 seconds, the Allen test is considered to be positive, and the arterial puncture should not be attempted at that site. The flexor retinaculum, also called the transverse carpal ligament, is a thickening of the antebrachial fascia. The flexor retinaculum attaches from the ulnar carpal eminence, shown here, which is comprised of the hook of the hamate bone and the pisiform bone, and it extends to the radial carpal eminence, shown here, which is made up of both the scaphoid bone and the trapezium. The flexor retinaculum forms the roof of the carpal tunnel, and functionally, it prevents bowstringing of tendons. In other words, when the muscles flex, putting tension on the tendons, it prevents those tendons from popping out. The carpal tunnel itself contains one nerve, the median nerve, and 9 tendons. Notice that no arteries course through the carpal tunnel. Here is the median nerve coursing through the carpal tunnel, which again, the roof of which is formed by the flexor retinaculum. And then notice all 9 tendons. There are 4 tendons of the flexor digitorum superficialis muscle, the 4 tendons of the flexor digitorum profundus muscle, and the tendon of the flexor pollicis longus muscle, shown here. And recall that all of these tendons are surrounded by synovial sheaths. Recall that the sheath surrounding the FDP and FDS tendons was referred to as the ulnar bursa, whereas the sheath surrounding the flexor pollicis longus tendon was referred to as the radial bursa. Here's a different perspective. This is the ulnar bursa. and the radial bursa. Carpal tunnel syndrome is the most common compression neuropathy. It occurs when the median nerve is compressed within the carpal tunnel from inflammation, typically from repetitive wrist or finger flexion. In the hands, the median nerve is important for tactile discrimination. For example, it helps you to differentiate between a penny and a dime in your pocket, for example. Some refer to the median nerve as the eye of the hand because of its important cutaneous innervation to the fingers. As a quick reminder, however, it does not innervate cutaneously all of the fingers, but only innervates the thumb, index finger, middle finger, and half of the ring finger. Carpal tunnel syndrome often presents with paresthesia, or numbness and tingling, in the lateral 3½ digits, that is, those digits innervated by the median nerve. There may also be pain or discomfort at the wrist, and in addition, long-term compression of the median nerve can lead to atrophy of the thenar eminence and weakness of those muscles. Notice this patient has a divot in the area of the thenar eminence. This represents atrophy of the thenar group of muscles. Recall that the thenar group of muscles was innervated specifically by the recurrent branch of the median nerve. Hence, if the median nerve is compressed at the site of the carpal tunnel, it will also have downstream effects. That is, it will affect the thenar eminence and that group of muscles, in addition to affecting the first two lumbricals. There are two common ways to test for carpal tunnel syndrome. If you palpate your radial artery at your wrist, you'll notice that it is immediately lateral to the flexor pollicis longus tendon, and subsequently just lateral to the median nerve. Using the radial pulse as a reference landmark, you can then move your fingers just medially toward the midline of the forearm. Here at the distal forearm, just proximal to the flexor retinaculum, you can percuss over top of the median nerve. This test is referred to as a Canal test. If the patient experiences marked pain and/or a lot of numbness and tingling in the fingers innervated by the median nerve, that would be indicative of a positive Canal test, which suggests the patient probably has carpal tunnel syndrome. A Phelan maneuver can also be performed. In this maneuver, patients place the backs of their hands against each other in order to induce hyperflexion of the wrist. If this maneuver causes the patient a lot of pain and/or paresthesia in the fingers which are innervated by the median nerve, then that indicates a positive Phelan sign. And a positive Phelan sign is indicative of carpal tunnel syndrome. By way of treating carpal tunnel, there are a range of various treatment options, from splinting to glucocorticoid injections to surgery. If surgery is performed, the flexor retinaculum is often divided to alleviate the pressure on the median nerve. The ulnar nerve and the ulnar artery pass through what is known as Guyon's canal, shown here. It is also shaded in this image in purple, and is known as the ulnar tunnel. The roof of Guyon's canal is formed by the palmar carpal ligament, shown here. This ligament is just a superficial extension of the flexor retinaculum. By way of landmarks, notice that this canal courses immediately lateral to the pisiform bone. Here's the pisiform bone in this image. Within Guyon's canal, both the ulnar nerve and the ulnar artery divide into superficial and deep branches. The superficial branch of the ulnar nerve, for example, is going to be responsible for carrying cutaneous innervation from the pinky finger and the medial half of the ring finger. The deep ulnar nerve is the motor branch, which is responsible for innervating all of the intrinsic muscles of the hand, except for those which were innervated by the median nerve. The superficial ulnar artery will contribute to the superficial palmar arch, whereas the deep ulnar artery will contribute to the deep palmar arch. Cyclists who place pressure on their hypothenar eminence from how they grip the handles of the bike can compress the superficial branch of the ulnar nerve. This typically results in a pins and needles sensation, which runs down the medial palm to the medial two fingers. If the deep ulnar nerve is compromised at Guyon's canal, then marked weakness of the intrinsic hand muscles can result. As a quick review, the deep ulnar nerve innervates the hypothenar eminence, that muscle group, as well as the third and fourth lumbricals. It also innervates the palmar and dorsal interossei, and the deep ulnar nerve innervates the adductor pollicis muscle as well. I can't stress enough how important it is for you to become familiar with all these muscles, their functions, and more specifically their innervations. By knowing this information, you'll be able to more efficiently localize certain nerve lesions. If I had to estimate, I would say that approximately 60% of all of the anatomy written questions that you receive on your summative exam will probably have something to do with a nerve lesion. For example, you'll likely be given the signs and symptoms of a patient, and then we'll have to work several steps backward to figure out what muscles are affected or which nerve is affected and where that nerve is affected. So keep that in mind as you prepare and study. Thanks so much for listening. This concludes the lecture on the extensor forearm and the hand. Take care.